All right, well, I am pleased and excited to introduce to you Mary Linden Salter. She is the Executive Director at Tennessee Association for Alcohol, Drug, and Other Addiction Services, or TADIS. Mary Linden has over 30 years of experience in the behavioral health sector. She's a licensed therapist who uses her clinical knowledge and experience to ensure programs and advocacy efforts are meaningful, appropriate, consumer-oriented, and grounded in best practices. Please join me in welcoming Mary Linden.
And my apologies to everybody to begin with. I'm the reason we started late. I could not find this building, so I'm sorry. TADIS is an organization that does a lot of different things, advocacy and other. We have a clearinghouse. Maria, there's a booklet that they're going to get too, correct? Can we pass? We're passing those out as well. The booklet that you're about to get is one of the many resources that we have available at our clearinghouse. And I'll just put in a quick plug. Everything that we distribute is free. Everything that we distribute can be ordered through the mail and sent to you in the mail for free. So if there's things that you like about this presentation, go online to tadis.org, check us out, and we will talk. You can see more about what we talk about today. My mission today is really to talk to you about kind of the nature of addiction and how we kind of come up with some of our core beliefs about addiction and some of the mental health and behavioral health issues associated with some of those beliefs. But let me start by saying that I have taken what was a 3-hour presentation and compressed it into 1 hour. So I know that there's things that I can't get to. Dr. Perez is going to talk about some of the clinical aspects of addiction. And I'll just say that other than saying it right now, the words amygdala and hippocampus will never come out of my mouth again. This is not a clinical overview. This is more like a conceptual overview of some of the things around addiction, our concepts about it, and our views about treatment and addiction over time. One of the first things I would like to challenge you to do is to think about where your core beliefs about addiction come from. And I ask this because they often cloud how we perceive people that we treat, as well as how we provide services. And I'll just be the first to share and say that my core beliefs came about because I have a mother who was a psychiatric nurse, and she worked at State Hospital number 3. They didn't even name them back in those days because there was no dignity, certainly, associated with being at State Hospital number 3. But the small town where I grew up in, there were roughly about 5,000 people who lived in the town. There were 9,000 people who lived in the institution. So it was bigger than the town. Before the Pentagon was built, it was the largest institution in the world. Think about that, the largest building in the world. 9,000 people, many of which who were addicts, epileptics, head injury patients, mental health disorders, developmental disorders, the full range. But it was where people went, that nobody wanted to have in their communities. 9,000 people. It was huge. It was about a mile from my house. And it was a huge, imposing facade, if you can imagine. It's been razed, actually. It no longer exists except for one historic building. But I grew up going to this facility with my mom at night because she would teach classes for the nurses at night. So I would actually get to meet patients. So I grew up really not having a lot of stigma or barriers about meeting what what many people would have considered to be dangerous or unlovable or, the dregs of society. And so when people talked about the institution, they talked about it as this, crazy house and, crazy people are there and dangerous people are there. My experience was the opposite. But that's very unique, very unique. I'll say that too, and also recognize that though my mom was a psychiatric nurse, on my dad's side of the family, we didn't realize until my grandfather passed away, but he had apparently had a brother that we were told had died, and right after World War I. Found out he was actually alive until I was 9 years old in an institution. Nobody ever talked about him. I never knew that he even existed during my lifetime. My father found out about it as well, and he had never met him. So we think about, the people that are put away, that we never talk about, that we consider to be unmentionable, and those are the people that we're serving, the people that most of our communities would consider unmentionable. Let me challenge you. There was a recent discussion through NAMI, the National Association of Mental Illness, that asked the open question: why isn't mental illness, addiction, whatever, why isn't addiction a casserole disease? And I ask you that because when you come home from the hospital with a broken leg or a heart cath or whatever, people come to visit you. They bring you a casserole. They say, welcome home. What can I do to help? And yet we don't do that with behavioral health disorders. And I would like you to think about that as we go through some of these slides and think about what we think about addiction and what we think about in terms of the people that we serve. The women who are often addicted and pregnant, you typically have more than just an addiction they're dealing with. Obviously, they're pregnant. But they very often have mental health disorders. They very often have traumatic experience as a core of what has gotten them into that situation. And that is true even of women that have become addicted to pain pills as a result of some prescribing practices that probably others will talk about in this room. But women, as a rule, have more traumatic experiences and have more behavioral health issues wrapped up in their addiction than men do. Okay? So you can get these kinds of thoughts, values, feelings, and flavor, if you will, for what you think about mental health and addiction through your family, your faith, culture, movies, and books. That poster is not that old. That's from the 1940s. We haven't quite decided if we embrace, the use of alcohol, or if we consider it a moral failing, or many religions still, talk about the fact that drink is evil, and it's not allowed at all in many religious cultures. So I don't know what everyone's background is in this room, but let's think about not that long ago. Many of the substances we're talking about were considered medicines. And those are from anywhere from the 1880s through the 1940s in that slide. It is not that uncommon to think about mental illness and addiction as possession by the devil. And I will give another disclaimer. I grew up in the Missouri, Kansas area, and there was a huge settlement of Mormons in Independence, Missouri, right outside of Kansas City. And my very first placement as a social work student was at a mental health center in Independence, Missouri, where the local hospital is run by the Mormons. The psychiatric unit there is run by the Mormons. And the entire culture that I worked in was Mormon. On our treatment team was a church elder who did exorcisms. And that was part of the actual psychiatric unit, because the belief system of the Mormons was that you had to cast the devil out before you could get better. This is in 1981. I'll date myself, but yeah, not that long ago. And that still exists on that treatment team in the Mormon hospital in Kansas City. So believe me, it's still alive and well with us. Those are some of the images that I grew up with. Who remembers the egg in the frying pan? Yeah. But this image on the top, the black and white picture, That's very much the image of the psychiatric hospital that I used to visit, where my mom worked. There were still brackets on the walls where they had chains to chain people up. The floor was slanted towards the middle, and I asked my mom one day why that was, and she said, well, that was so the urine could run off. They would literally chain people up and just let them be there. So, not that long ago. I don't know about you, but when I went to school, there was a huge debate about nature versus nurture. And you, as a clinician, almost had to make a commitment about what you believed as you went through school. I think even then I questioned why I had to make a choice. But I think now we've come to full circle and really believe that it isn't all or nothing. We know it's not black and white in real life, and I think now we've come to realize it's not black and white in science either. There's really a juxtaposition of those two things. Nature affects nurture, and nurture affects nature, and there's really no way to separate the two in most cases, although there's certainly certain composites and certain issues that certainly come out with certain cultures and certain people. But I think what we now know is that it's both. What I do want to talk about a little briefly, because this is going to be kind of an overview of many of the other slides that I talk about, is the concept of resiliency, especially when we start talking about trauma. And this has interesting impacts too when we talk about nature versus nurture. But there's been a lot of studies about those two factors. And this particular study that I talk about in this slide really came to the conclusion that it's not a question of genes versus the environment. It's how genes interact with the environmental factors. And this was the first study that really talked about the nature of resiliency and the fact that resiliency factors can help people overcome what may be a genetic predisposition. So when we talk about resiliency, we need to conceptualize things that are protective factors that help people succeed and the skill set that will help people get better no matter what their circumstance. In some cases, the most loving of families cannot necessarily instill resiliency factors that will help people cope with addiction. And I think that's a hard lesson for families to understand. Teaching kids to be obedient, for example, sounds like a great attribute until you realize that if you teach a kid to be obedient, a sexual perpetrator often preys on them because they will just do what they're told. So what you may think of as resiliency factor isn't always something that helps keep people safe. Being able to negotiate and discern, right and wrong for themselves is often a better resiliency factor than being able to do well in school, follow the rules, and, fit in, so to speak. Have you ever noticed, and people talk about this on everything from Saturday Night Live to whatever, that if it's the geeks that are taking over the world, right? That's what we're talking about. It's people who have figured out how to fit their own way that are often the most resilient. Does that make sense? Okay. So, all right. This slide is, I wouldn't even ask you to read it. Don't worry about that. But this is kind of the prevalence of addiction issues in the last 12 months. This is for, it doesn't say, I want to say it's for 2014. But I thought it was on this slide and I don't see it. Anyway, alcohol continues to be the most prevalent addictive substance. Tobacco's right behind it. Right behind that is cannabis, caffeinated drinks, and whatever. The first, what you consider to be an illicit substance, so to speak, is cocaine, quickly followed by mushrooms and amphetamines. Opioids is solidly in the middle in that graph. But we know that opioids is an epidemic in terms of prescription practices too. So I just wanted you to see that demographic. Oh, it is 2014. One of the things that I did want to point out, though, is that, especially in this state, very few people are actually accessing addiction treatment. There's an addiction treatment pot of money that the Department of Mental Health and Substance Abuse Services funds for people who don't have access to insurance and whatever, and that pot serves about 13,000 people a year. There's roughly about, we're just under this statistic, we don't actually serve 11% of the people in Tennessee with addiction. We only serve about 8%. So it's very low. There's 250,000 people in Tennessee that have self-identified that they have an issue with opiates and opiate prescriptions. That's just opiates. That's not alcohol or any other substance. So 250,000 people, and yet we're treating roughly 25,000 of those a year. Okay, what is addiction? This is where I try to gloss over it and concede to Dr. Perez, but one of the key concepts I wanted to talk about was that the addiction, yes, it takes over the brain, so to speak. People who are addicted, their brains have been modified in such a way so that the signals in their brains have been modified, and they crave and desire that drug because their brain is telling them to. Essentially, equivalent to the signal like when you're starving, that you need that substance. So, if we all think addiction is a disease, and most of the people in this room are medical professionals or work in the field, have heard that addiction is a disease, right? Is that true? So what does that mean? Is it like diabetes? Is it like, I don't know, cancer? Is it the same kind of concept that you have in your brain about addiction as a disease versus other things? What's your concept about that? I think what we know scientifically might be different than what we think conceptually or through our own culture and values. Scientifically, we know that chemical pathways in the brain are changed by those addictive substances. The structure of the brain may not be altered, but the way the brain processes things is interrupted and altered. So because neurotransmitters are interrupted, and that includes dopamine and serotonin, things that, quote, quote, make you happy, then our ability to seek happiness and to be happy in a bad situation is also affected. So we all know about neurotransmitters. That's in the book that you're being passed out as well. It's just communication. It's getting information from one side of your brain to another, or from one side of your brain to the muscle in your arm to tell it to move. But those neural pathways can be interrupted a lot of different ways, not only because dopamine or serotonin might be interrupted, but also because the signals themselves, the electrical impulses and things, can be affected by the chemicals that are in your body. I'm going through these fast. Okay. There's all kinds of things that can affect your brain and can affect things it can affect those neurotransmitters. And that can include things like plaques. You've probably heard that concept talked about with Alzheimer's disease, for example. Genes can cause different brain structures, so your actual genetic structure can predispose you to addiction. You've probably heard that it runs in families, right? Psychological trauma. I'm sorry, I said psychological. That too, but physical trauma can also alter the brain. If you've had a head injury, particularly in the frontal lobe, you often have poor impulse control, and that affects your ability to manage things like addiction and other issues. Psychological issues and trauma, and I'm going to talk more about that. Alcohol use literally alters it. Chronic alcohol and drug use can lead to something called to a dementia-like syndrome. There's actually a syndrome of a kind of dementia that is caused by chronic alcoholism. So it literally can destroy enough brain cells that you are unable to function as though you had dementia. So this is just kind of an FYI. You can see some of the differences in brain scans of people with addiction. And you notice that there's a difference between somebody who uses something like cocaine versus somebody who's an alcoholic. But at the same time, some of the very same kinds of patterns are present when somebody is obese. And we're going to talk about that as well, just briefly. This is a hard one to conceptualize, but when we do something like, for example, in this slide, eat lasagna, do anything pleasurable, a warm hug, a compliment, just feel like, you're enjoying your world that day. Your brain lights up in certain areas. You get those pleasure impulses can happen. However, with addiction, that prefrontal cortex, that center that lights up, becomes affected. So your ability to differentiate, and actually understand what your brain is experiencing is affected. So oftentimes, because of that alteration, I'm not even able to speak this morning. I got so discombobulated trying to find this building. Anyway, what I'm trying to say is that because of those alterations in your brain, your survival center kind of kicks in and tries to figure out how to function, how to keep you alive, so to speak, because of those alterations. That's particularly important when we start to talk about trauma, and that's really the reason that I'm bringing this up at all, because those core functions, those fight or flight functions that unconsciously tell you this is what you have to do to survive, because if you thought too long about it, you wouldn't be around long enough to survive, are the things that kick in when your body is faced with an addictive substance. And we'll talk about that a little bit more now. Think about what this woman has probably gone through, and may not even realize that how addiction has affected her, because she's so wrapped up in seeking a substance and believes that substance is what is going to keep her alive. Her brain has been tricked into thinking that. She seeks it and seeks it and seeks it to her own detriment, and because that is how she perceives her world. Does that make sense? Okay. So, because addiction disrupts the survival center of the brain, it disrupts self-preservation. Addiction disrupts awareness of your environment and your ability to process that information. And I think this is key, because so often you hear people like, why don't they just stop? Can't they just see what they're doing to themselves? And this is really hopefully something you can take away from this lecture about what addiction does to the brain. They don't see it. They don't perceive it. If they did, they would stop. But their brain has been hijacked, so to speak, by this substance. And blaming them for what it is they can't see or figure out how to change doesn't help them solve the problem. It's being able to help them understand how to use those resiliency factors and how to use things like motivational interviewing and other techniques to help them change those perceptions, to begin to take a step towards recovery, that it will help them. Does that make sense? Okay. Why can't addicts just quit? And that, I think this is redundant. I've basically already said it. Because those survival-oriented factors are the most primitive areas of the brain. One of the key things on this slide that I really wanted to talk about was that because those addictive substances kind of take over areas of functioning of the brain, it can take at least a year of abstinence before people can actually be back to a fully functioning status. With a lot of brain functioning restored, brain cells actually regrow, and they can come back. But think about what that means in terms of addiction treatment. People aren't able to fully recover and really able to process information the same way that they probably used to without at least a full year of treatment and or sobriety. That's why they talk about a 1-year sobriety being such a key milestone, because that's when hopefully enough healing has taken place that the person can actually begin to think more like they used to process information, to be more invested in their own recovery. Those resiliency factors have really kicked in, and the person is using them probably to their best extent about a year after they've been in recovery. However, it's also important to remember that those neural pathways are laid. They're still there. So things can trigger that person, and if something, some key issue or some happening in their world sends them back to a place where they were using in their mind, that neural pathway that's laid that says you must do this in order to survive, that survival function will kick in. And they will often go back to using because that's all they see. They go back to that fight or flight modality of I must do this, I cannot cope, I'm at my last wit's end, and they have no ability to think beyond that, because it's just like that fight or flight moment. Your brain tells you if you stop and think, you're dead, right? So those fight or flight, things kick in your brain. You're not processing it logically. You're processing it automatically. And when those automatic responses kick in, you do what your brain tells you to do to survive. So that's what's key about helping people recognize triggers and manage their relapse in a way that helps them manage those triggers and situations so that they can avoid those things and help lay enough new neural pathways for at least a year and beyond so that their ability to cope, their resiliency factors are in place, and they can actually get past that without hopefully using. Or if they do use, they manage it well. They look at a relapse strategy differently, and they continue a path towards recovery. Okay? Okay. Learning new skills creates new pathways in the brain. And I don't have a watch with me, so diet 15? Okay. So just like you exercise your brain in learning math skills or whatever, you have to exercise your brain and learn recovery skills and learn things that help you build resiliency factors and build some of those key concepts about what recovery means to you. And it's different for every person. There's no script that can tell you exactly what you need to do, each individual. But I've had people who immerse themselves in art in order to be able to figure out how to forge new kind of concepts of self-awareness and self-worth through art. I've had people do it just by actually bonding with their families and their children. That's a key concept for women, to be able to rebuild their lives and to focus on resiliency factors not only for themselves but for their children, is being able to keep those family units intact. So cognitive behavioral exercises are important, and they're an important part of recovery, but just know that you can retrain your brain. Anybody can retrain their brain towards anything. That's what we do in cognitive behavioral therapy. I wanted to talk a bit about relapse. I just touched on it briefly, but relapse is an important part of managing a recovery process. You can't go into treatment with somebody without talking to them about the fact that they have to manage those triggers and manage potential relapse. At the same time, you have to do it, like I said, to build resiliency factors. Relapse is devastating for people who are in treatment. It is not an easy thing to get past. If you ever felt moral failure for having taken that first drink, you certainly feel it for having relapsed. And so it is a hard thing to help people get through, but it's an important part of the discussion. And what I try to do as a therapist is help people understand it in terms of things like diabetes, for example. I don't know how many of you have somebody who's diabetic in your life, but I've literally watched people who are diabetics say, well, I'm going to, shoot up X number of milligrams of whatever it is, of insulin or whatever so that I can have that piece of cake. So they manage what I would consider to be mini relapses throughout the week. And they just do it because they figured out how to kind of do it within certain boundaries and I'll say get away with it, but whatever. But I think that's true whether or not you're a heart patient or an asthma patient or whatever. You are managing a chronic disease and you relapse. I'm asthmatic. I am constantly wheezing. And I'm constantly trying to figure out what to do to manage that. And I will forget to take my medicine, and I will go hiking anyway, and I will do all kinds of things because I'm trying to enjoy my life and at the same time manage my asthma. And I think that's that's a disease management concept that we need to think about as clinicians. How can we help people manage a life that's productive and happy, that gives them the benefit of wanting to build on resiliency factors, and at the same time recognize that they're managing a chronic illness. Just like you would manage your own chronic illness, it's hard. You relapse. So not punishing or stigmatizing people who have that is an important part of helping them manage their illness. Does that make sense? Okay. I don't even think I'm behind, so I'm not even going to do this one. We're going to talk about trauma. Our responses to stress are kind of defined about how we've coped with trauma. And I would venture to guess that if any of you have clinical experience working with women, you realize that trauma is a key part of what they bring into any behavioral health treatment environment. One of the things I always tell clinicians when I'm talking about CBT and whatever is to remember that trauma is more pervasive than you think, and never go into a situation where you don't presume trauma. There's likely going to be trauma. You just may not know what it is. So the same areas of the brain that regulate some of those responses, like fight or flight, also regulate things like the sleep cycle, food and water and intake. But one of the things that's key to understanding the nature of the correlation, actually, of trauma versus addiction is that the same things that the brain responses that are responses to trauma can lead to things that people use to self-soothe. That's very key. Food is a common self-soother. Food addiction, whether, there's a lot of debate in the field whether or not that actually exists, but those are things that lead to other chronic illnesses as well, like diabetes, hypertension, and obesity. But there's also drinking, that can come out of that self-soothing behavior. And, sex and other pleasurable activities. Sex addiction has gotten a lot of press these days too. But anything that people, constantly need to do to feel better is something that is often comes from a traumatic-based experience. So this is the ASA study. I think a lot of people in this room are actually already aware of it. But this is a long-term study that's been going on. Kaiser Permanente started it, I believe, in the 70s. What has come out of it is a recognition that there's a lot more pervasive trauma issues for children and even for adults than we ever thought. And the link between those childhood traumatic experiences and long-term addiction, heart disease, diabetes, all kinds of issues. The more traumatic childhood experiences you have, the higher the likelihood you are to have some of those long-term chronic physical illnesses. It's important to remember that trauma is not an event. Trauma is your response to the event. You can be in a horrific plane crash, and one person will walk away and be fine, and the next person can walk away and be completely immobilized for the rest of their life, never be able to get on a plane again, and anytime a siren goes off, they're absolutely jumping the walls. Two persons, same exact experiences, but different responses because they have different, you want to take a guess? Different what? Resiliency factors, right. They have different ability to cope. They may even have different genes that predispose them to react differently. They have different life experiences. They have different social networks that may actually be able to help them respond to that event. One may actually get access to therapy and the other one doesn't. That's also a factor in how they're going to respond. But those traumatic experiences kind of lay down a new neural pathway where that experience has been, or that response has been associated with a very traumatic experience that has initiated that fight or flight response, that immediate, I must do something to survive. Therefore, anytime it's triggered, their panic attack, their urge to go drink, their, whatever it is to self-soothe becomes a pattern as well. If they don't have good resiliency factors, or if they don't have something that helps them cope with that situation after the fact, their self-soothing behavior to manage the anxiety and that, or anything that comes from it, flashbacks, you've heard of PTSD, those flashbacks are the brain reliving that experience because it's been triggered. And so they go into fight or flight mode. They may do things very angrily or, very, in some cases, dangerous behavior, or just things that are self-destructive because they think they have to survive. Okay? I think this is one of my favorite metaphors. It's probably because I'm a gardener. But just think about trauma in terms of laying a neural pathway the very first time it happens, because that event has been heightened by the fact that it was that fight or flight, signal to the brain was part of that experience. That neural pathway is laid deeper than many other kinds of experiences in your brain. So you'll go to it without thinking about it, because your brain again, it's wired to keep you safe. But the first time it happens, that pathway is laid. When you think about watering a garden, and you put the water and the hose down that garden, and you lay it down, and you turn it on to a certain kind of, water pressure, it's going to lay a pathway, right? You turn it off, you let it dry. What happens? You can kind of see the outline of the water, right? You turn on that spigot, you don't move the garden hose, you don't do anything different. You turn on the spigot to the exact same water pressure, what's going to happen? It's going to exactly follow that same path, right? Unless you do something to alter it, unless you move the hose, unless you turn the pressure on differently, unless you move the garden, rows, the exact same thing will happen every time you turn on the spigot to the exact same pressure. And that pathway just gets deeper and deeper and deeper, but it never changes. And if you have a traumatic experience like child sexual abuse, where somebody comes to you regularly, night after night after night after night, and you can't get away, that pathway is deeply, deeply rooted in their brain. There's no changing that path. Does that make sense? Okay. Trauma's influence. I have 5 minutes. Okay. I am going to briefly talk about this, but there's all kinds of things that trauma does to affect the brain. It elevates your stress hormones. One of the key things that I want to talk about on this slide is that trauma affects learning because it affects memory. If you had a lot of traumatic experiences, your brain is almost in a constant state of you've heard about hypervigilance being a symptom of PTSD. When you're constantly trying to figure out who's going to hurt you next, you don't have a whole lot of time to settle your brain on learning math or learning resiliency factors. Okay? If you have to manage all those fight or flight symptoms before you can settle down enough to absorb new information, that's something you need to think about as you're thinking about the treatment issues that you put into play in your treatment programs. These women have a hard time settling. They have a hard time, dealing with the emotional baggage they have, putting it aside and being even able to take in new information. Okay? We've already talked about long-term healing and stuff. That was a slide. That was a billboard that was done by a mental health advocacy organization. But I want to come back full circle again and talk a little bit about how trauma-informed practice might change programs or access to services, or how we treat women who are unable to settle themselves and at the same time have a baby who is unconsolable. Okay? These are things that affect how we provide treatment. They're things that need to help us understand this woman who's having a hard time figuring out how to cope herself. She's going through addiction treatment. She has a newborn baby that's very, very hard to console, and is going to be a difficult transition for her at its best. Much less if it's not. So think about what that means to your programs, to your own sensibilities. I just would continue to challenge all of you to think about what you bring to the picture. What are your values? What do you think about people who have addiction issues? If you think it's a moral failure in any way, shape, or form that's going to impede your ability to be a good clinician with these ladies, and it's going to color their ability to recover. So do you have any questions? None? Okay. Well, thank you for the opportunity, Lacey.